Hello, welcome to APHA's Addressing the COVID-19 Crisis, an open forum webinar series for pharmacy. My name is Sandra Leal and I'm president of the American Pharmacists Association. We're really excited about today's topic for the webinar. Today's topic, we will be discussing pharmacy approaches to dispensing COVID-19 oral antivirals, including key considerations for implementation, patient and provider education, documentation, and billing. All very, very topical areas. We have two great featured speakers today. First, let me introduce Lisa Smith. Lisa is the Senior Director of Clinical Strategy and Operations at Walmart Pharmacy. For the last several years, Lisa has been working on clinical operations in the pharmacy and advancing non-dispensing functions, including immunization, medication therapy management, and point of care testing. Throughout the pandemic, Lisa has been Walmart's liaison to federal and state public health. Lisa started her career with Walmart as a pharmacy intern and 13 years later has held many roles both as a pharmacist and in market and regional and divisional field leadership positions. We're very happy to have here. We also have Tori Grooms. She is a PGY1 community-based pharmacy resident with the University of North Carolina Eshelman School of Pharmacy and Moose Pharmacy located in Mount Pleasant and Concord, North Carolina. Tori graduated from Belmont University College of Pharmacy in Nashville, Tennessee, and is passionate about community pharmacy, practice transformation, and new clinical service developments. We also have with us today two subject matter experts. Mitch Rothholz, he's the Chief of Governance and State Affiliates, and he's also the APHA Executive Director for the APHA Foundation. Mitch brings a long history at APHA as our vaccine expert. We also have with us today Elisa Bernstein, Senior Vice President of Pharmacy Practice and Government Affairs, and she brings 30 years of history at the FDA. So let's review the format for today's webinar. So we will just have an open discussion with Lisa Smith and Tori Grooms, and then we will go to the open forum discussion at about 1:40 to share your questions and thoughts. So please feel free to add those in the comment bar. And then we will review in the last 10 minutes APHA's activities and what's coming up. So some open forum ground rules. We have the GoToWebinar toolbar to submit questions and comments as you're hearing the topic discussion. We will try to get to as many questions and comments as possible during today's session. We also have the handout that's available for you to download and to reference. So make sure you do that. And then we will be recording this webinar and make it available once it's concluded. So we will now bring on Lisa and Tori to join me on screen so that we can begin our discussion on this very important topic. Welcome, Lisa and Tori. Thank you so much for everything that you've been doing and working on. I know there's just so much information around the COVID oral antivirals, and so we're really happy to have you here today. So let me start with the first question, and let me start with you, Lisa, and then we'll go to you, Tori. I'll try to go back and forth as we're speaking here. But can you talk, Lisa, briefly about your practice organization and your involvement up to date with the COVID-19 oral antivirals?
Yeah, absolutely. Thanks for having me. It's really great to be with everybody. Similarly to how we handled the vaccines, Walmart has been a participant in the federal retail pharmacy program. So working directly with the CDC and HHS in this case to be able to provide vaccines and now therapeutics to the country. A little bit different than the vaccines, but how the vaccine started is really this is a state allocation process at this point. So the states are given an allocation and then they can select partners for which they would transfer that allocation. We would coordinate on sites and then put that product in those sites. So currently we have about 1,300 pharmacies at Walmart Live in over 20 states, and that seems to be growing every single day. But we work in partnership to make sure we're helping the jurisdictions get the most coverage possible. So that's our participation so far.
Oh, well, thank you for sharing that. And I'll ask you the same question, Lisa, or I'm sorry, Tori. What has your participation been thus far?
Yeah, so we have kind of jumped out of the monoclonal antibodies and then started to transition into recommending the oral treatments for patients in our community. I represent a smaller independent pharmacy. So we are an independent pharmacy chain because we do have 7 different pharmacies. But all of our stores are now carrying the oral COVID therapeutics. And we are mostly carrying both products, but have a mixture of offering Pfizer and Merck options. So that's kind of where we're at in our process.
Very good. Well, thank you both for sharing your involvement there. So we'll go to the next question. So Lisa, could you please provide an overview of the available COVID-19 oral antivirals and the pharmacist's involvement?
Yes, absolutely. So currently, pharmacists are really in a dispensing only factor with this product right now. There isn't the availability for a pharmacist to actually prescribe the product. So it does come from a prescription from a provider that is licensed in that state. The pharmacists are dispensing, but as we'll get into later as the questions go on, there's a lot that goes into dispensing these. So it's certainly more involved than just a regular dispensing and consultation that we might be used to. The 2 available products are the Paxlovid, which is the Pfizer product, and the Molnupiravir, which is the Merck product. There is definitely more availability nationwide of the Molnupiravir, the Merck product. It has wider allocation, and therefore from our footprint, we have it in more stores. We do have stores that are carrying both, but Paxlovid, one has been in higher demand, but also more limited allocation nationwide based on the current supply of the federal government. So both of these products are available for pharmacists to dispense. Hopefully at some point there will be a test and treat type application for the pharmacist, but currently, because of the way the EUA was released, it is a dispensing only function at this time.
And how about you, Tori? Any comments or anything to add to what Lisa mentioned?
Nothing to add to what she's mentioned. I think we'll keep going on with the discussion, and it will definitely grow from here.
Perfect. All right, that sounds good. So Tori, can you review what makes a good candidate for therapy? I know that's been a question, like who qualifies and how do you evaluate for that?
Right, so these medications aren't for anybody, and they're not for everyone who tests positive for COVID-19. And part of what we do out of our pharmacy is help in screening patients. So we don't just take the prescription and fill it, but we are active part of the healthcare team and making sure that our patients are eligible for these therapeutics. So we do ask for a proof of a positive test. We don't require them to document and send that into us, but we do want confirmation that each patient is positive and not trying to use it for prophylaxis. We make sure that the patients are still in the mild to moderate COVID severity, so that they aren't having those O2 sats less than 94 if they have a pulse ox, or if they're extremely out of breath when we're talking to them on the phone, we're able to kind of catch on to those things. But for the most part, patients are getting these therapies very early on, so we're not falling in that severe category. But one of the main questions that comes up with therapeutics is how long they have been having symptoms. So there is a cutoff of less than 5 days max for symptom onset in order to start a therapeutic. So we do screen each of our patients and make sure that we are counting. First day is considered day 0. So as you're trying to figure out how to count those days, first day will be day 0. Your next full day of symptoms will be day 1. So giving your patients 5 days there. And then these are for adults. For the most part, the Pfizer is eligible for patients that are 12 years and older, and then the Molnupiravir is 18 years and older, but we do still have the same weight of 40 kilograms for those. The other big important thing is screening for risk factors. So like I said, it's not just for everyone who tests positive. They have to be one of those patients that fall into a high risk category. So those have been pretty well established and published. So most of our patients have an understanding if they are high risk or not. But that's still one of our screening questions when we receive prescriptions and we make contact with each patient. So we're asking about their age. We ask them how much they weigh and how tall they are so we can calculate their BMI. We ask about their other conditions, if they have diabetes or heart disease, lung disease, any sort of immunosuppressive type disease, liver and kidney disease, which is important later on as we take a look into their therapy, and also asking about pregnancy or potential for future pregnancy. We like to screen for that as well. And all this kind of takes place on the front end. As soon as we receive a prescription, we have a technician going through these screening questions to help make sure that we've got good candidates for each therapy.
Yeah, it's amazing. There's a lot of things to consider. So definitely have to keep track of all of this and make sure you're finding that right individual for this therapy. Thanks for sharing all of that.
Yes, ma'am.
Because of this, what is a training that you need, or what have you all provided for training for making sure you're evaluating people? I'll start with you, Lisa.
Sure. So one of the things that we want to make sure before we place this product in any of our pharmacies, that our pharmacists have done a thorough review of that EUA for healthcare providers. There's certainly the EUA fact sheet for patients and caregivers that we give out, but really doing an in-depth review of that EUA for healthcare providers. It lists all of the drug interactions, especially as we think about Paxlovid and ritonavir. There's a pretty significant list there to work through, as well as understanding all those contraindications. So really just the expectations that we would have anytime a new drug comes out, but with this one being a little more involved, we want to make sure all of those reviews have happened. Also, all of the key counseling indicators that Tori walked through. Operationally, one of the things that we're doing, most patients are coming the same day because it's an acute need and they want to get started, and they're high risk anyway, so they want to get those symptoms resolved. But we are also running some reports in our will call bin to see if we got any prescriptions that the patient hasn't come and picked up yet. Once you get past that 5-day window, they may miss their opportunity to initiate therapy. So we do have our pharmacists doing some follow-up on a prescription maybe we received electronically where the patient hasn't presented to pick up that medication yet.
Great. And I just wanted to point out that APHA has some really good resources, information on these therapies that include some of that detailed information on evidence, contraindications, and counseling. So I want to make sure people have that. It's in the slides for you to download, and then the links to watch, because I know these, as you mentioned, Lisa, have so many considerations, and you want to make sure that you have the availability of these resources to you. So hopefully you download that link and reference those. But I'll ask you the same question, Tori. What are you doing in your setting regarding training for these therapies?
Yeah, so we were one of the first pharmacies to start rolling out the oral antivirals. So we had to kind of come up with some of our own training to get everyone up to speed. And one of the things that we did was take that fact sheet and condense it. So we've just got a one-pager that we have reviewed. So we're very knowledgeable on all the details of the fact sheet, but we also have a quick one-pager to keep things fresh as patients ask questions, providers ask questions. This has been our go-to for provider outreach as well. So we're able to help providers make the best use of their time, and before they dive into the 29 or so page fact sheet, they can just take a glance at this and get a quick understanding of these drugs. So that's something that we've kind of taken on as our independent side.
That's good. Definitely have to figure out how to fit it in. There's so much information, and I'm glad people are attending this. This is a good way to stay up to speed. So let's see. So let's go ahead and talk about, how each of you is working to ensure that patients who need this have them prescribed, especially given the short window of time. You mentioned the 5 days. But how are you doing that? How are you reaching out to people to ensure that they're receiving this if they need it? And I'll start with you, Lisa.
Sure. So I think one of the things that we realized right away is we have had vaccine for some time in every one of our locations. So it was potentially going to be a little bit confusing to both patients and prescribers that we had more limited availability of these products. So we stood up a store lookup tool that can be patient facing. The HHS has a larger tool that is more provider facing, but patients or providers can put in their zip code and see not only which Walmarts in their area are carrying the product, but one of the things that we realized was going to be super important as well was which product we were carrying. We had some pediatric patients in areas where maybe we only had molnupiravir. So both knowing which product was available and where is really, really important. So that's directly linked to our inventory in real time, whereas we report daily to HHS so that inventory can be a little more static at that point. We also have just some quick infographics that you see on there about what patients can expect. We are working very hard to make sure that these symptomatic COVID positive patients are not in our stores and interacting with our normal customer base. So we are serving these customers through our curbside, drive-through, ship to home or delivery models. So it walks them through, stay in your car, call the pharmacist, we'll consult with you, we'll get everything ready, we'll come out to you and get that medication to you. So just walking those patients through that, but knowing where the product is available is really, really important. We had a lot of prescriber confusion at the beginning, and so being able to direct them to that site so they know exactly where and how they can get the product is critical.
No, that's really key. I'm so glad that you did this tool, because I can imagine immediately think about health equity and looking at access points and being able to identify that those are all really key. And then I also appreciate you taking care of the staff as they're trying to take care of sick people, right? Like having these different processes in place to make sure everybody is safe, including the people that are working. So that's great. Love the infographics. Thanks for sharing that. Tori, can you share your experience?
Yeah, absolutely. So for us, in ensuring that our patients are getting this product, it kind of worked two ways. So we already have established COVID testing in our pharmacy. So we're able to start with some patients from instantly, as soon as they know they're positive, we're able to follow up with their doctors, let them know after having conversations with patients, knowing their ages, knowing their health profile, if they qualify, and if we should take the time to reach out to their doctors. So some people were able to start the process for them and reach out to their doctors and get those prescriptions sent over. And then for some, it's happening less organically, I guess. So we're able to just educate our community through social media and through educating our providers. And that's been key. As this was so new, our providers didn't even know what the drugs were, who was eligible, etc. So for us, it's been the most important thing, just working with our community to make sure that everyone understands who qualifies, who can get it, and where they can get it from.
Oh, that's great. I love that word of mouth, and people talking about the services you offer. That really goes a long way. So glad that you're using some of those tools like social media. So just a question on following up to this. How is it going so far? How has the distribution of this been working out for you? And it's nice to have you both compare and contrast, one more from a national level, and then Tori more from that local level. So I'll start with you, Lisa, from that global view.
Yeah, absolutely. So with the product being allocated directly to the jurisdictions, there was a lot of coordination that had to occur. We're at a place with the vaccine where we are getting national allocation for the larger retail pharmacies, and we're distributing it more like how we would do flu or other vaccines. With this working directly with the jurisdictions, there's a lot of differences state to state. So some states picked community pharmacies right out of the gate and chose where they wanted that. Others have been slowly coming online. Some started with the health departments at hospitals or at federally qualified health centers. So it's been a little different in each and every state. As I mentioned at the top of the presentation, Paxlovid has been in much shorter supply than molnupiravir. So the other thing that we're starting to see is that there seems to be like we're gaining enough molnupiravir to go around. So, and as cases are falling nationwide, we're seeing it move a little bit slower. Paxlovid tends to still be in pretty high demand and shorter supply. So that's something we're continuing to collaborate with the jurisdictions on, is where should we put product. We also ran, Sandra mentioned health equity, we ran social vulnerability index numbers, worked with the states to make sure that we had the vaccine in the communities that would need it most, and making sure that we always had a health equity lens as we were distributing the product as well.
Well, that's great to hear, and I'm glad you're using that tool to be able to do that. And Tori, how has your experience been on that more local level with your 7 different stores?
Yeah, so for us, it's been a little bit more like one-on-one working with our state health department. So we're communicating directly with our state health department to request allocations. And we have to wait. There's doing a bi-weekly cadence for these allocations. So you have to request your allocation, wait and see if you've been approved and allocated doses or not. And then, a few days later, receive that shipment. So it's a slow turnaround, but at least we are still receiving shipments, and we're able to work directly with that state health department to ensure that our patients are getting these doses.
Very good. And I'm just going to add a related question that's coming in here. Is this drug a limited distribution drug?
It is not a limited distribution drug. It is held, it's kind of a tough question. In the traditional specialty sense, no, it is not a limited distribution drug. It does have some requirements that are reminiscent of a REMS type drug with the pregnancy indications, but it is neither of those things. It's limited only in that it is owned by the federal government and allocated by the states. So it's limited distribution in the sense of how you can obtain the product. It's not open market because the federal government is the owner and buyer of the product at this point. But in the traditional, how we would use that word in the specialty space, it is not a limited distribution drug.
Oh, thank you for that. And I can imagine this is impacting your workflow just because there is so much to consider. Look, can you talk a little bit, and I'll continue with you, Lisa, to start, and then with you, Tori. But how are you meeting those extra requirements to dispense this medication, especially with everything that you've mentioned around evaluating the patient and then the considerations?
Yeah, so it has certainly taken extra time to work with these patients, to work with the prescribers. I know we'll talk about reimbursement a little bit later, but that's certainly been a challenge. But when you think about the workflow, just the way that we're approaching it, as I said, one of our first priorities is that we keep these patients away from our healthy patients, customers, and we protect our staff in the process of dispensing these medications. So when an electronic prescription comes in, we are reaching out to the patient, asking them, if they or their caregiver will be coming in. Certainly if they have someone who's not quarantined or not COVID positive, they're welcome to come into our stores and pick that up. But if they are needing to pick it up themselves or their whole family is quarantined, we direct them to our curbside or drive-through or ask them, alternatively how they would like to get that. So that certainly takes time. Then we have all of the work that Tori mentioned in evaluating, is the patient eligible? Is it a woman of childbearing age? Do they have other medications? There's significant drug interactions, renal or hepatic impairment. So working through all of those things that are really a normal course of a pharmacist DUR, but really having a lot more going on with this particular product. Then both dispensing and counseling the patient and the requirements around the EUA fact sheet. There's also some education, Tori touched on it a little bit, but with the prescribers. We need a legitimate prescription coming in with all the correct information on it. That means choosing which product the doctor is prescribing. It's actually called out in the EUA that there's detailed SIG requirements that have to be on there. So making sure that our pharmacists have SIG requirements that are matching the EUA, and then the full consultation that would go on with that patient. So it's definitely significant. Our pharmacists are getting really good at making it work in workflow, but it's definitely taking more time than the average prescription would.
Yeah, I can't imagine. I mean, it looks like there's quite a bit of a shift with the usual dispensing workflow to be able to accommodate this. And what's your experience been like, Tori? And then I know that you've also been doing testing. How are you incorporating all of that plus what you've been doing already?
Yeah, so our usual workflow has changed significantly. And it's not the most formal thing, but I did bring like our workflow document. So we are processing this checklist along with every prescription. So not very modern, but it works. So as we receive a prescription, our intake technician is going to immediately call the patient's phone number that's listed on the prescription. We're going to verify that that's the best number to reach the patient at. Most of these are not our existing patients, so we have to verify their insurance in addition to screening them for their eligibility, like I covered previously. So we're screening them, making sure that we're also obtaining a medication list. Again, most of these patients aren't our normal patients. And we need to be able to run the drug-drug interactions. So we request a medication list. If they know their meds and they only take one or two, then we'll take it verbally. Otherwise, we'll request it directly from the doctor who sent the prescription, or whoever else we need to get a hold of, even specialists at times. So we have to do all of that, and then also let the patients know that we are strictly doing curbside pickup for these medications. We do still offer free delivery, local delivery to our patients, so that is an option if they are local. But for the most part, we're doing curbside pickup. Even if they have a family member, we encourage them to also do curbside just to be extra safe. We are located in a very small pharmacy, so it's very convenient for us to just run out the door and deliver the meds right to their car. Another part of our consult and that initial phone call with them is checking on their symptoms and what else they need as far as support meds. That way we can kind of be like a one-stop shop for patients. So we're screening and making sure, if they need some cough syrup or Tylenol, or if they need immune support, we have a whole menu of immune supporting supplements that we offer to them as well. So that's just what happens before we even start to fill the medication. And then we fill the medication and it's sent down to the pharmacist, and the pharmacist has to put on their clinical, cap and start really thinking critically about what to do with drug-drug interactions. Unfortunately, it's not as easy as just saying, hey, don't take this for 5 days, because it could be something that they're taking for epilepsy, or, no telling what all. There's the EUA lists 29 different drug classes that interact with Paxlovid. So that's not medications, that's drug classes. So there's a significant list of drugs that we have to be, thinking very critically. And so whenever we run those screens, we have to take the time to not only just see, hey, yes, this is a severe interaction, but dig into the actual literature to see what is the interaction and how is it going to affect the concentrations of their maintenance meds. So we've had several that are not just as simple as discontinue for 5 days, because it might only decrease the concentration by like 10%. So you have to think, well, how can they adjust their regimen so that they can continue to take their meds safely, but account for, these changes. So it's definitely a lot more time involved. We have run some tests and timed it out, and it seems to be taking us about 40 to 45 minutes to go through this process. So after we're running their drug interactions, we're calling up the patients, trying to explain this to them and how they need to adjust their regimens, how they can safely take this medication. And this service is a whole different ball game outside of normal dispensing. And we do definitely consider it a whole different service that we offer to these patients. And you mentioned offering COVID testing with this. So you could just kind of throw that onto the front of workflow and getting them started out in the parking lot with their COVID test, getting that positive, and then starting the rest of it and just adding more time and effort in. But it's very significant, and it's been very good for our community, but it's helping us to get new patients as they see and really respect what we do in this care.
Oh, that's tremendous. I mean, what you've described with 29 classes is incredible, and trying to go through that and make sure everybody's safe is amazing to me. I do love that you have a checklist. I think about the checklist manifesto, and trying to make sure you're not missing any steps in this very complex and complicated process, but truly at the end of the day, really, providing a life-saving intervention there. So, the question that I have to follow here, Tori, is the renal adjustment. That's one of the things that I know has been one of the critical items. How are you managing this, especially, with the renal function? How are you receiving renal function? How are you obtaining that information so that you can make that adjustment or recommendation based on that?
I think now we can pretty much trust our providers if they tell us, this dose should be renally dose adjusted or not. In the beginning, that was something as they were sending prescriptions, and most of them were either called in or faxed in the very beginning. EHRs weren't even set up for it. And we were having to verify, do you have the serum creatinine? Do you know this patient's renal function? So now we are mostly trusting it, but again, that is a part of our screening question. So as we ask patients, do you have a history of kidney disease? If they speak up and say, yeah, actually, I have had that before, and we've got a prescription for a full dose of Paxlovid, then we're going to call and follow up and question it. So that's just, another layer of the care. If we do confirm that they do have some sort of kidney disease and we need to adjust their dose, these medications are blister packed, but is very clearly packaged to where the inside tablets can be punched out and covered up with a sticker that has the corrected instructions for how the patient should take the medication. So that's, physically how you have to do it. And then as you punch out those tablets that the patient should not be taking, you've got to figure out a way to dispose of them in your pharmacy. I know that's one of our kind of follow-up questions. But here at our pharmacy, we do have a drug take back box, so we have a way to get rid of those so that we aren't, held liable for having some unlabeled tablets laying around the pharmacy.
Oh, that was going to be my follow-up question. How do you discard them once you remove them? So it looks like you've got the take back box. How about you? Are you doing a similar process, Lisa?
Yeah, we're using our normal hazardous waste drug disposal process in the pharmacy. So that was a big education piece for our pharmacists. I think it's counterintuitive to have a drug in short supply that you're needing to dispose of when you have, pills that haven't been dispensed. So hopefully there's going to be a solve for that where we're not disposing of them, but that is the current direction because we don't have a way to label them appropriately and they're not packaged in a way that they can be stored after that. So we're using our normal hazardous drug waste disposal system.
Very good. I'm receiving a question here just because it's related to this, but initial concern was that the people would hoard these drugs or docs would prescribe for family members to have on their shelves, like we saw with hydroxychloroquine early on in the pandemic. Are you seeing any signs of this with this experience?
We have not seen the scale that I saw with hydroxychloroquine or ivermectin or some of the other therapies that have happened before. I think because of some of the things that Tori described, the process our pharmacists are working through in conjunction with the EUA, assuming that people are being truthful in the questions that we're asking them, there's a lot of checks and balances to go through there, the symptom checking, the making sure that they are have comorbidities that would be associated. So there's a lot more checks and balances associated with it. It's also in much shorter supply. And so I have not seen the same things that we saw with some of the other medications up until this point.
Great. Well, that's good to know. I imagine it would be quite difficult with all the hoops that you just talked about. And how about you, Tori? Has that been your experience also?
Yeah, I would completely agree with Lisa. I think with this much of thorough screening, it's very hard for someone to slip through, especially if they're not a COVID positive and don't have symptoms, then we're able to redirect we also have, you know, the long-acting monoclonal antibody Evusheld. So if it's someone who just seems nervous and wants to have something to protect them on hand, we can usually kind of direct them to a better line of therapy there. So
Yeah, I would also say we've gotten questions, surely, about prophylaxis. So people are calling. That's definitely a question that we got. Someone's going overseas, someone's traveling, you know, can I take it with me? And so those are things that we've had to say that, you know, no, there is no authorization for prophylaxis at this time, and working back through the EUA language.
I can see that being of interest for sure. Good point you bring up here. And then the next question I'm going to ask Lisa is around fertility and pregnancy considerations. I imagine that comes up quite a bit and concerns around that, but can you speak a little to that as it applies to the two products?
Yes, absolutely. So this is something that our pharmacists are definitely having to screen for, and a lot of questions coming in. So with the molnupiravir, it is contraindicated in pregnancy. It has some really heavy pregnancy and fertility warnings associated with it. So when we have particularly those women of childbearing age, making sure that they're not pregnant, and then also that they're using protection while they're on the product, and then for at least 4 days afterwards. So there's a significant amount of education that needs to happen there. And then with this one, I think differing than some of the other medications we may be used to with these types of black box warnings is because it's just in the EUA stage, there really hasn't been a ton of information on male fertility and genetic abnormalities that may occur with the sperm of men whose partner may be of childbearing age. So there's actually a recommendation that males use contraception for actually 3 months after. So it's a pretty significant amount of time. So making sure that our pharmacists just aren't focused on those women of childbearing years, but also men who may have partners who could become pregnant. Then on the flip side, you have Paxlovid that may actually interfere with oral contraceptives, so causing them to be less effective. And so needing to have those conversations with women who may be using hormonal contraceptives, that they should have a backup method and just be aware of that particular drug interaction. So really some significant considerations on both sides with these products.
Well, that's incredible. I mean, I hope people listen to that about the recommendations because they're so specific and length, 3 months, you know, for condom use. That's incredible. There is a question here about pregnancy test before dispensing. Have you seen that as a recommendation or?
So it's not required by the pharmacy. I think certainly on the provider side, if you had maybe someone who was attempting to become pregnant or wasn't sure of their pregnancy status, if a woman told us that they didn't know, we would certainly make a suggestion that they attempt to verify a negative pregnancy status before starting the drug, but it's not required, and there's no REMS type requirement. That was a concern when the drug was in clinical trials, that there would actually be an Accutane type REMS program associated with it, and that was not something that came to fruition.
Very good. All right. So I know this probably requires a lot of documentation, but Tori, can you talk a little bit about that, what you're documenting and, you know, what reporting is involved with this, with these products?
So we do a lot of documentation, but what is actually required of us is honestly quite minimal. So the only requirement is the daily HPOP inventory that we have to report. So that's just asking how much is on your shelf and how much you've dispensed in a day. So that's what is required for us to document. But then in addition to that, some of the extra things that we document here at Moose Pharmacy includes our consultations and how we discuss these drugs with patients. So in that last end of our workflow, when we finally touch base with the patients as a pharmacist, we review how to take the medication and how they need to adjust their other regimens. If they are taking other medications and we advise them to take their medications differently, then we document that. Just so that we have that, you know, in writing somewhere, but that is documented in each prescription in our pharmacy software system.
Very good. And how about you, Lisa? How are you handling that?
Yeah, very similarly, the actual reporting requirements programmatically with HHS is fairly minimal. You have what you received and what you dispensed. Obviously, there's some on-hand adjustments and different things that are required for that renal dosing that Tori talked about. But other than that, very similar, just your normal clinical documentation that you would do through consultation or solving DURs for other medications in the prescription management system is how we're handling that.
Very good. So, we just talked a lot about the evaluation and then the documentation. So given, all of these advanced dispensing activities to be safe with these products, how much time on the average are you spending to dispense these products per patient? General response. I'll start with you, Tori, and then go to you, Lisa.
Yeah, so we actually have timed it, and we have some that are relatively fast. So, on the faster end, we can get through it in about 30 minutes. And then most of our patients are falling more in the 40 to 45-minute range. And again, we have very complex patients that come to our pharmacy. It just in general. And then we also have a very intensive, workflow that we have worked out and that we feel comfortable with. But this service for us, it takes us at least 40 minutes to get through the average patient. So it's extensive for sure.
Definitely. And Lisa, how about you?
Yeah, I don't have as detailed of exactly down to the minute, but certainly more than your average prescription. And I think when we're thinking through the drug interactions, many of these patients are complex by nature because they qualified because they were high risk. And so I think the drug interactions are actually more common than not because they're going to have an underlying comorbidity that puts them at risk that they're more than likely on a medication for. And so we're seeing more trending towards the complex than the non-complex just by nature of the eligibility criteria.
Yeah, no, absolutely. I mean, I think, the time that you're investing in this is incredible. And then, I mean, the impact to prevent a person from ending up in a serious hospital situation is a significant, impact to their health. And then the total cost of care, I'm sure. And so let's talk a little bit about reimbursement, because you are investing so much clinical time and expertise and then trying to maintain safety and provide access and health equity. But let's talk about that next. What are the reimbursement pathways available for COVID, oral antivirals? And before I start with that, I do just want to ask a question that came in earlier about cost sharing. What is it costing patients, one, and then what are you actually seeing from a reimbursement to cover all of your services for this? So I'll start with, yeah.
Oh, so this is a great segue because it sets it up perfectly. With the provider agreement that allows pharmacies to obtain these products to dispense, you actually agree that you will not have any form of cost sharing. So there is no cost to the patient. You cannot charge a copay or pass any of the dispensing fees on to the patient. It is a zero cost, zero retail medication. We are getting it from the government at no cost, and then we can utilize a dispensing fee to assist in covering costs, but none of those costs can be passed on to the customer. So your billing avenues are really traditional pharmacy medication billing. Most of it is going through the PBM or Medicare Part D. There is the availability of HRSA, to bill HRSA funds for the uninsured, so very similar to the vaccine program. HRSA did recently come out with their rate of $12, and other than that, it is very much commercial billing, inclusive of Medicare Part D. It is not covered under Medicare Part B, as in boy.
$12. Okay. And Tori?
Yes. So $12 is generous from what we have found in across our pharmacies. Yes, we are not charging our patients. I will say though that when we do run it through commercial plans, we do find plans that will if you run it through the plan, it will charge the patient a copay. So the way they are set up on their side, they do have that copay built in, and we have to just zero it out and make sure that the patient does not actually pay anything for these medications. I said the $12 is very generous because on our end, we have run reports, and on average, we're getting $3 to $4 per prescription, with many of them being in the pennies. So that $12 is generous, but it's still not anywhere close to what we need in order to be able to safely dispense these medications, given the time that it takes to do it. We're seeing that, that $12 on the high end is still only roughly about 10% of the cost of our time and our resources to fill one prescription. And then, thinking down to those prescriptions that are getting paid reimbursements in the pennies, it's just very, very hard for any pharmacy, but especially a small business pharmacy like I'm in, to be able to maintain a service like this, even though we know we have to ethically, take care of the sickest of the sick, and we want to be able to offer this, and we really want to be able to help our patients. We're kind of put between a rock and a hard place with dispensing these medications.
Yeah, absolutely. I mean, I'm just thinking about everything you've described and how much time, effort, safety, evaluation, 29 drug classes. I'm sure that wouldn't even cover the first minute, for the time and an investment. But I'm going to ask this question next. What steps would you do differently, if you had prescribing authorities for these medications? Because I'm sure some of the steps would be facilitated and then access as well. So I will start with you, Lisa, and then go to you, Tori. Anything you would do different?
Sure. Yeah, I think prescriptive authority, you would really be, one, paid hopefully for that assessment fee. So that's one of the big things that we need to have happen in order to be compensated for that prescriptive authority. But most of our pharmacies and many across the country are already offering testing. So it really allows that end-to-end customer access point. So certainly would increase access to therapy. But I think actually the processes would look a little bit more of the same. I think there would be some areas we would want to dig into a little more. Tori mentioned the renal and hepatic impairment, make sure there was a clear understanding of that, and some of the other indications. So I think there would likely be probably some inclusion-exclusion criteria that would need to be developed for who can be serviced at the pharmacy based on what each pharmacist, kind of felt comfortable with, and may need to refer out in different cases. But I actually think the end-to-end workflow would look fairly similar. There would just likely be a process of billing for that assessment fee on the front side, in addition to dispensing the medication.
Okay. And how about you, Tori? Anything you would do differently?
Absolutely. I mean, we were active in treating COVID-19 patients with REGEN-COV. So in that scenario, we were able to test the patients. When they tested positive, we could screen the patient and order the medication, which to me was pretty much a taste of provider status. We did not have to follow up with their doctors to request that prescription. We were able to do it right then and there, and line up some appointments for patients to get treatment. So it would be ideal if we could, order these medications. We're already doing such thorough screening. We really, at least at Moose Pharmacy, as this was rolling out and we started to catch wind of it, we were preparing for test and treat. So that's why I think our workflow is, so absolutely in depth, is we want to make sure that we are doing everything possible to take care of these patients. So we are doing everything that I think would get paid for if we had that model set up and we were paid for that assessment. It's just waiting to see, how we can advocate for our profession and hopefully get more of a medical billing type aspect to this dispensing.
Yeah, and I mean, I think what you pointed out about the patient experience also, right? If you have to have several appointments and then come in and get the medication versus the other option that you'd already implemented before, I always think about inconvenience and the multiple visits. When somebody's already sick, to me,
Right.
that can usually be very challenging for people. So
Right.
hopefully.
It just creates more delay in treatment. So we have patients who test positive, and then we have to reach out to their doctors, and then their doctor wants to see them as a telehealth visit, and then it might be the next day before they even send them the prescription. So if we were able to say, hey, you're positive, you are on chemo treatments, we know you need medicine and you need it now, we'd be able to get that initiated much, much faster. It'd just be so much more efficient for our patients.
So there was a question here related to, let's see, just the renal function. Are the doctors doing that pretty routinely? Are they handling that okay? Or just any issues around that? Or when you call them, like if there's any concerns, are they pretty positively responding to you for adjustments?
Yeah, we've had great response. We've had, some people kind of right on the cusp and been able to have conversations with providers of which way they think that the patient should go. We've also had some really, really elderly patients who they've prescribed the full dose for, and we've kind of questioned it with them, and they've been very responsive to our our recommendations that maybe they should cut back and do half doses for those patients. So it's been tolerated and done very well with them.
So this is my last question, and I thank you so much for your incredible experience. But the key question is, how have patients responded to therapy? How have they reacted, having gone through this process with you, the access you provided? Any feedback, any people responding, saying they've had adverse reactions or very positive responses? I'll start with you, and then I'll finish with you, Lisa. Tori first, then Lisa.
Yeah. So I can definitely share. I think we might get more like personal feedback on the medications. So our patients are ecstatic. Everyone has tolerated it extremely well. We have not had a single patient call back to report an adverse reaction. So as far as tolerating it, very, very well. And then as far as recovering from COVID, also extremely well. We've had some very sick patients who've come back and said that they probably would have been in the hospital if it hadn't have been, for having treatment available, because they just knew, if they're on chemo or they have, no immune system, they know that the hospital would be where they would end up. And so now I think one of the major things is that we're able to offer them hope. So there's now an option available, and they see that it's working, and they're telling all their friends that it's working. So word is definitely getting out that there's therapeutics available for our sick patients.
That's great to hear. How about you, Lisa?
Yeah, I would echo the same. Really, really good tolerance as far as what we're hearing. And I think really it's been extremely gratifying for our staff. I think what Tori described is exactly what patients are feeling, which is a huge sense of relief, a sense that they have an active step that they can take in trying to keep themselves well. They're extremely grateful. So I think as much as our pharmacists are taking a ton of extra time, people are so appreciative of that time that's being taken. So I think extremely rewarding for our pharmacists to be able to assist patients in that time of need.
Very good. Well, thank you so much for sharing your experiences. It's amazing. I'm always so impressed about what pharmacists can do out there, the access they provide, the equity, and then just really preventing people from having, bad outcomes or a very long visit to the ICU. So thank you so much for all the work that you both have been doing, and to your colleagues also. So thank you. I'm going to invite Elisa Bernstein now. We were going to go ahead and do the APHA activities and what's going on. So Elisa, thank you so much for joining.
Great, thank you. That was a fantastic discussion. Thanks, Tori, Sandra, and Lisa. So actually, I'm going to give you an update on some activities that are specifically related to what we were just talking about. So as some of you, I assume maybe most of you are aware that APHA and pharmacists all around were waiting and expecting that when the oral antivirals were authorized, that pharmacists would be able to prescribe, which because of the authority under the PrEP Act. But the authority under the PrEP Act still flows back into what the limitations and conditions in the EUA. And in the EUA authorization for these products, there were they specifically identified which prescribers can prescribe these products, and pharmacists were not included. And as we heard just, in the last 40, 50 minutes, that basically all the steps that pharmacists are taking are even more steps that a prescriber would be taking, and in addition to that. And so one area of advocacy that we have been focusing on is working with FDA to give them the comfort and confidence and any information to open that EUA to give pharmacists who want to be able to do this. Now, granted, we just heard that it's very time consuming and not all pharmacists have the time to do this. But for those pharmacists who can do this, who want to do this, we're working to try and expand that authority to add pharmacists as prescribers. And so this is a work in progress, and we'll wait and see, because in those communities where the pharmacy and the pharmacists are the only healthcare provider, it's really will make a difference to patients' lives. So on the other side of the coin, as we also heard on the next slide, that the dispensing fees are pitiful and pennies. The most that we've heard is the $12 that the government is paying for uninsured patients. But for the most part, it's so not worth the time. But the fact that this is these products are really good options for patients. So we also are working closely with HHS and the private sector to find ways to make the dispensing fees, and this is just dispensing, put aside that if pharmacists have prescribing authority, make the dispensing fees mean something and really stand behind the time and effort that it takes for pharmacists to go through the steps to ensure that these products are appropriate for patients. So this too is a work in progress, educating the government, educating plans and PBMs in trying to make sure that rate is significantly higher. So on the next slide, another area of advocacy that's we just launched at APHA just last week. Recently, CMS issued a proposed rule addressing Part D requirements. And in that proposed rule was a provision to move the DIR to the point of sale. So any DIR fees the retroactiveness of them would be moved to the point of sale. And so this is in a proposed rule. We've been there, done that before, that this was proposed and it was never finalized. And we need your help. We want you to tell CMS to finalize the rule in a way that benefits patients and pharmacies. We have some language for you to put in a comment and an easy button on our website for you to cut and paste those comments as is, or you can customize it with your own experience and submit those to CMS. So we go to our website. You could find it easily. Here's the URL. Comments are due by March 7th, but get those in early. I would say early and often, but really you just need to do it once. But it's important that you do it once. So thank you very much for helping in that, because that'll really help our profession. And if you go to the next slide, is a reminder that APHA has a pharmacist guide to coronavirus with a number of resources to help you related to COVID. Specifically, as we showed earlier, we have some resources and some CE programs related to the oral antivirals. So bookmark this. Everybody should have this website and web pages bookmarked and go there also often. Sandra, back to you.
Thank you. Great information, Elisa. Thanks for continuing to advocate for us every day. I just want to remind everybody that we have an annual meeting in March. Hopefully you can be there in person. live, we have the registration page here with very critical information about San Antonio and Texas. There's a QR code there for registration. So please join us. We'll have a great event. I know a lot of people want to catch up in person, and we have new therapies available. So hopefully you feel safe. We have a lot of precautions in place to make sure everybody does well during this meeting. And I look forward to seeing you there. The next slide is around our next webinar. We will have one scheduled for Thursday, February 24th from 1 to 2 Eastern time. You can click through the register here to register for that. We will be talking about updates related to vaccines, testing, and treatment for COVID-19. There's so much going on with this that we want to make sure you're all caught up. And we will make available this recording as soon as possible. So it'll be available in our open forum webinar library through the link listed here. Thank you so much for your time, and thank you to our two speakers today, Tori and Lisa. Again, thank you for all the work that you're doing, and thank you, Elisa, for all the information. Have a very good rest of the week, and thank you so much for attending.